thank you, everybody. It looks like we have about 20 or so people on board here today. Thank you, everybody, for joining us again for another episode of our Town Hall series, Be Well, Virginia. I appreciate you all joining us tonight on a beautiful night. Tonight we're excited because we're addressing what we consider a very important topic, which is colon cancer prevention and screening. And this is really important because colon cancer is the second leading cause of cancer deaths in the US, and it's preventable. So whenever somebody dies of colon cancer, it's a shame because typically it's a preventable condition. So tonight we're going to let you know what you can do to help prevent it or catch it early. And specifically, our guest is going to give you those pointers. And our guest tonight is Dr. Sean Hurley, who is a board certified gastroenterologist with digestive disease physicians, it's hard to say, in Alexandria. And he is somebody that we refer many of our patients to and in whom we have great trust as a physician. He's a wonderful physician, for those of you who haven't met him. Dr. Hurley got a bachelor's in science from Notre Dame University and then went to medical school at Georgetown University, go Hoyas. And he completed his internal medicine residency with the Air Force at UC Davis in San Antonio. And in 2007, he joined practice with digestive disease physicians. And he has a broad range of specialties in GI illness with a particular focus on colon cancer screening that we're going to talk about tonight, acid reflux, celiac disease, Crohn's, and colitis. Thank you, Dr. Hurley, for joining us. We're excited to have you here.
Great, thank you, Ken. And thanks to all of you for having me on this town hall. We were talking earlier, some of you may have gotten on as we were talking right before this, about how great of an idea I think this is, and that this town hall and the different educational forums and discussions, I think is wonderful. So thanks for asking me to be a part of it. I actually recognize some names there in the forum. So hello to everybody that I know and to those that I don't as well. And thanks for asking me to talk. Obviously, this is something near and dear to our hearts as gastroenterologists and what we do all day, every day, big part of things. And so, some of my background with training in the military, practicing in the military, includes some work in the VA system as well. Been through several different academic centers around the country, sort of different models of patient care and practice that I've been able to participate in. And then as you mentioned, I've been here in Alexandria now for quite a while. I finished up my military assignment at Andrews Air Force Base in 2007. So I was chief of GI there. We did lots of colon cancer screening, obviously a big part of what we did. Also a lot of general GI, Crohn's, colitis, that sort of aspect, which is another of my particular interests. And so when I left there, I went into private practice here and have been in private practice at Alexandria. We are in the large white building by the Mark Center. So everybody, that's the Alexandria Professional Building over by Alexandria Hospital, which is where we've been in practice. And so I thought what we would do today, we had actually talked about several different topics and ultimately decided with the recent March being Colon Cancer Awareness Month and then putting this together, we thought this would be a timely topic to cover. And as you can see from the slides, this is through one of our societies, which is the American College of Gastroenterology, who's really embarked on a vast undertaking to try to get the country screened. And through multiple reasons, as we'll discuss some, there's been some hesitancy on getting screened. It's a procedure not everybody wants to talk about. It's a day off of work if you're going to do a colonoscopy. It's kind of a sensitive area for many people. So there has been a big promotion over the years to try to educate physicians, patients about the importance of screening, the different methods of screening, why we do this. And so hopefully you'll find this talk informative. And certainly if you have any questions, I'm told, I think that you can type them in, and then we will address those as we go along, and then have time at the end for open forum discussion as well. So the big emphasis is on, with colon cancer, it is a very, very preventable disease. And many of the cancers that we all get screened for in this country are not always preventable. They might be diagnosed at the time of one finds a cancer, but these we actually can prevent by finding the precancerous stages. So it is a very common cancer. It's the third most commonly diagnosed cancer in both men and women. Very preventable. It is responsible on most years for the second most common cause of death from cancer in this country. And so that's why we target so much effort here. With regular and routine screenings as done through your primary care doctor and or your gastroenterologist to identify and remove polyps, we're really able to reduce about 90% of colon cancers. And so that's a vast improvement over the years through some of our techniques, through the bowel cleansing process that's continues to improve, and with patient awareness to the importance to get screened. So this next slide just kind of covers what I was alluding to before. You know, as men, when we go in for prostate cancer screening, we're really screening for cancer. We're not really screening for the precancerous changes. Similarly with mammograms for breast cancer, but for colon cancer, because we recognize that the polyps are the precancerous stage, often will take many years to grow. If we identify those and remove them, then that's how we really are able to prevent colon cancer. So again, prevention, not just detection, removing the precancerous polyps. And if you remove these polyps before things start, then you will also have identified an individual as being at higher risk, and we know we need to keep a closer eye on them. If you make it to 50, 60, 70 years old and have never had polyps, then obviously the risk is going to be a little bit less, and we're able to lengthen those intervals of screening. So just kind of an overview so we all are on the same page here. So this is a diagram of the colon, essentially an upside down U, as we like to say. It is marked here by initially when one has a colonoscopy from the rectum to the sigmoid colon, the descending. This transverse colon goes transverse across the upper abdomen to the ascending colon because it rises from the right side, ascends up, as opposed to the left side, this descending colon descends down. And then we have the cecum, which is the portion of the colon right by the appendix in the right lower quadrant. So this is as if someone's, the right side of their body, they're facing us, and where the colon would lie. So a lot of times I'll get asked how long the colon is. It's actually for many people about 5 feet long, which is pretty long, obviously. And so we're trying to examine a relatively long organ in the colon, but we have different techniques with colonoscopy that allow us to do that relatively easily. So again, removing polyps, you'll see this is their major theme that we're trying to get promoted here. And this slide really shows basically everything that we're really focused on. So you'll see on the far left that cells start to kind of proliferate, and then they develop into these small precancerous polyps, which are the common kind of polyps we see all day, every day, very common. They're benign, but what we call precancerous. And so that term is initially somewhat scary to people because they hear precancerous and they think, oh my gosh, I must have cancer. I'm about to get cancer, tomorrow. And that's not the case. For the vast majority of these are small to maybe medium size. But if they're left in place over years, then they can eventually grow to cancer. So that typically for many people would be this progression from a small polyp. Again, the adenomatous polyps are the benign, but the precancerous kind, to the larger polyps, to dysplasia, which is a term used for very aggressive cell changes right before they become cancer. This white is meant to represent the cancerous part within the polyp. You can see even here, if we were to remove this by putting a lasso around the bottom here and cutting it off, you could still cure the cancer. But once it gets to this point and the cancer has started to evade down into the tissues, that's the true malignancy that we all worry about, because that requires surgical resection, might require chemotherapy. If it's in the rectum, might require radiation. So this is really what we're trying to prevent by removing these areas here. The exact length of time of this process is not the same for everyone, and it probably depends on family history and some determination as to whether the polyps are sticking up or whether they're flat, which is a unique polyp called a sessile serrated or a flat polyp. So, but the general thought is probably in the 8 to 15 year range. We obviously want to get these early so that they don't become later on. The colon polyps, again, themselves are typically harmless. Occasionally, if they get large enough but not turn into cancer, they can cause some bleeding, but the vast majority will have no symptoms. And remember when I first started, and even still now, many people will come in and say, oh, I'm fine. I'm here because my wife told me to come, or I'm here because my husband told me to come, but I'm fine. I have no issues. Well, which is wonderful, but the vast majority of people that we see don't have issues. They don't have bleeding. They don't have abdominal pain. They actually feel fine. And then we often find polyps. So when we do find those and tell people, we often will also recommend that their siblings might get screened. And again, even without symptoms, it's more based on age and family history, as we'll see. These are some examples, and I apologize, but for a gastroenterologist, a picture is worth 1,000 words. So I thought people might be interested to see some of what we actually look at when we're talking about these. So it's always a little bit gross, but it's also very real. And what we find, and you may, if you've had a colonoscopy, you may have seen pictures from your gastroenterologist that show different sorts of polyps. So on the bottom right here is this small little kind of circular polyp. You can see on the top left, this much bigger, I mean, you know, anybody really could look at that and say, you know, that doesn't look right. The tissue up here is the normal tissue, and here is this growth, which still looks benign, but is relatively large. And then you have a polyp here. So these polyps, this particular polyp, are what we call a pedunculated polyp. So polyps do come in different shapes and sizes, and we talked a little bit about the flat polyps. The pedunculated polyps are those on a stalk, so kind of like a tree trunk or a shrub. And these we often remove, we'll put a lasso around them, and then sometimes we'll cauterize the bottom, and then we clip them off. And these pieces are always taken to the lab for the pathologist to assess. And then here on the left lower, you see a much larger polyp. This is starting to get really red and irritated, which we would like to, we'd like to see them, if we're going to get them here before they become this large. But even some of these large ones can still be endoscopically removed, and so important to identify and find. The other thing that is very, very important is those were examples of much more obvious polyps. The one on the right here, I think, is still probably fairly obvious to many people. But what's not so obvious is this one on the left, and hopefully you can see my cursor here. But over here on the left half is actually a very, very flat polyp. And this is really important because this underlies why the gastroenterologists are so fastidious about the bowel preparation. I think far and away, many patients will find the colonoscopy not as big of a deal as the preparation, because the colonoscopy, the anesthesia is great, you're asleep. For the vast majority of people, they're very comfortable. And so that's not as bad as the preparation, because obviously you have to get cleaned out. And sometimes you may see that we use extra incentives to get cleaned out because people tend to be constipated. They might be on medications that slow down the intestinal tract. And so that extra effort, though, really is worth everything. And the diet following that is obviously there for a reason, because you might well imagine this is hard enough to see with a high definition equipment on a good day when the colon's nice and clean. If there's puddles of liquid still there, they can be actually quite difficult to see. And so that bowel preparation, although not fun, really is a very important aspect of things. So again, finding precancerous polyps. So colonoscopy, obviously, as a gastroenterologist, that's what I spend a large amount of my time doing. And the colonoscopy is actually the most common GI procedure done in the United States. And in many ways, I think we're very fortunate in the United States. We have a lot of gastroenterologists. We also have a lot of access to equipment. Many of the countries, they don't have this. They might have one person doing colonoscopy for, servicing a wide area, and people will have to come. And so they don't target screening. They're dealing with symptoms that they're focused on. And so we're very fortunate in that we have this. And again, helps us prevent up to 90% of colon cancers. As some of you may have seen, colonoscopy often involves a flexible tube like this. It's literally a black tube. It has amazing advancements. So in the old days, as you might imagine, before everybody had all of the high-tech stuff we have now, it was all done through optical. So it was like a microscope head on the top of a tube, and you would have to literally look through a tiny lens that would transmit the image from the tip of the scope all the way back to the GI doctor. And now with flexible scopes, with innovations in high definition, we're really able to see so many things. And so through cautious manipulation through the colon, we make several different turns here, as you can see up here, and we come down. So the goal is to cover all the way from the cecum, or where the appendix is, and then all the way back. And again, typically this is done in the United States with sedation. Anybody who's had that before, again, typically it's a very nice, gentle sedation. You go to sleep quickly, wake up quickly. There's little after effects, although you do still need to have a ride to drive you home that night. So it is a commitment for that day for sure, for the colonoscopy. This is an example of what we might do when we encounter a polyp. So again, on the upper left, one can see the polyp here. It's a little hard to see, but on this far upper right, the gastroenterologist has injected a slight blue dye underneath the polyp, which is designed to raise it up to make it safer for us to remove it. And then this picture shows what's happened after the fact. So the gastroenterologist has a device called a snare, which goes around the polyp, cinches it tight, and then cauterizes it. And then you can see here that there's no polyp tissue left. And there's the nice blue that was left behind, which was the part to elevate the polyp to make it safe to remove. And then this is the polyp after it's been removed. And again, we suction those pieces and send them off to the lab. So I think that's colonoscopy. And obviously, that's a big part of what I do, as we said. But really what we need to understand, I think, is who's at risk. And really, it's both men and women to a significant degree. And we will see people who come in and say, oh, that's more for men, or that's more for women. Really, the difference is not that much. So if you think about these numbers, 1 in 23 to 1 in 25, depending if you're a man or a woman, that's a significant number of people who, if they age and do nothing, will eventually, it's estimated that they will eventually develop colon cancer. And this is why this is so important, those 1 in 23 numbers. And that's helpful to think about with risk reduction. It's helpful to think about, is it really worth pursuing a test to see if I might have colon cancer because the risk is so high. Interestingly, there has been some trend towards an increased risk in polyps, which has led us to start colon cancer screening now at a younger age. And the reasons for this are not totally understood. My suspicion, and I think the suspicion of many, is the obesity epidemic, the sedentary lifestyle, the supersize fries and 7-Eleven supersized drinks and all of that. I think what we eat does get translated into other things that we have, certainly things like diabetes and fatty liver, but also many cancers, and that would include colon cancer. So some big factors, and hopefully one gets from this talk that even if you have none of these factors, you're still at increased risk. If you're used to be 45, now if you're, used to be 50, now we're targeting 45. But there are some things that one needs to consider that might put a person at increased risk. So one of the biggest things is a family history of colon cancer or of these adenomas or precancerous polyps. And what I'm always amazed at, the polyps are actually quite common, as we discussed, and many people will come in and their family will not have told them that they had polyps. So they'll often tell me in the office, oh, nobody in my family has anything. And then we set up a colonoscopy, and then they come in for that and say, oh, you know what, I checked with my 3 brothers and they all had polyps. And so that's very important to ask and to get that history, because people don't always volunteer, especially about their colon, and they think it was no big deal because the polyps were removed. But that's pretty important. Cigarette smoking, obesity. Unfortunately, they put in gallbladder removal, and I couldn't erase this. There's a very, very minimal increased risk after the gallbladder has been removed, which it doesn't change anything on how we approach an individual. But the concern is that if the extra bile gets dumped into the colon, that may precipitate something. But again, it's such a small risk that that really doesn't get conveyed into anything else as far as our screening intervals. Physical inactivity, abdominal radiation. So if you've had radiation for cancers of any sort, that can increase the risk of colon cancer, rectal cancer. Anybody who's had cancer of the uterus or ovaries before age 50 may have a genetic predisposition. There's some conditions we treat called ulcerative colitis or Crohn's colitis, which are chronic inflammation of the colon. And those can be much more serious and lead to a higher risk of colon cancer. And then as we've noticed over the last 10 years or so, maybe more, there's been a much higher rate of colon cancer amongst African Americans. So about 8 years ago or so, we started being much more aggressive if someone was African American. We now have looked at the numbers more recently, and frankly, the entire country has had an uptake in colon cancer in their 40s. And so that's responsible for the new recommendations, which just came out in March, suggesting that everybody come, even without a family history, at the age of 45 to come for screening.
The 45-year-olds are not very happy about right now.
I know they are not.
One of them.
I realize that. But, I'll tell you anecdotally, for a long time, even before these recommendations came through, we have been seeing as a GI community a significant number of polyps. And it's always a little disconcerting when you might do a colonoscopy for another reason. Say someone comes to us with diarrhea and we wind up doing a colonoscopy and we find polyps and they're only 40. And we thought, our traditional paradigm was to start at 50. So I think we're very happy now to have guidelines behind us and consensus throughout the country that this is the right thing to start doing. Again, often no symptoms, but if you do have symptoms, those should never be ignored. So rectal bleeding, while often from hemorrhoids, should not be assumed to be from hemorrhoids. New change in bowel habits, thinner stools that are persistent, left lower pain or pain anywhere in the belly. Those are all things that one should consider as we talk about looking for colon cancer. You do not need to wait for symptoms, as we just discussed these. The other thing is obviously anemia and weight loss, which I hadn't touched on too much, but sometimes those can be from different cancers as well. So even if you don't have symptoms, get screened. So screen. So how do you get screened? And there's a couple different ways to talk about it. And they've talked kind of more recently about a new paradigm. I think us as physicians have always thought of either do a stool test, which used to be checking for blood, could still be that now, or now we have what's called a DNA test on the stool, or do a colonoscopy. The GI societies have kind of started to think of it as you either do a one-step test or a two-step test. And a one-step test is the thought process of you just get a colonoscopy. Many would suggest the gold standard. And it's kind of what we call one-stop shopping because it takes care of any polyps that you see at the same time. So although it's more cumbersome, it is a day off of work, there is anesthesia, it gets everything done at the same time. And it's really the test that has the highest accuracy to find cancer and to find polyps. But we also recognize that at times people don't get colonoscopy for different reasons, whether they're fearful of the procedure, whether they have too many medical problems that it's not safe for us to do. And so the best test is really a test that gets done. If one doesn't get any test, that doesn't help anybody. So we're really trying to target awareness and then getting a test done. And so colonoscopy, I think we've already talked about in depth. We remove the polyps, and that's really where the long-term benefit comes. The other thing is the two-step screening process. And this I want to spend a moment on because I think people are becoming more and more aware of these testing options, and we are certainly seeing people opt for these options. It's called a two-step again because if it's positive, a colonoscopy is then essentially mandatory because the positivity, while not specific for colon cancer, certainly raises concern that there could be colon cancer. So for years, we've had this thing called a FIT test, which is a fecal immunochemical test, which is typically done through your primary care doctor on an annual basis. So it's kind of easy because you just have a stool smear and then they test it for blood. It's a little bit hard from the standpoint of nobody always wants to give a stool sample, at once a year, every year, but one time doesn't equate to an adequate screening. And that's why they've made the recommendation to do that on an annual basis. And again, if it's positive, it means a colonoscopy. The newer kid on the block, which is exciting from our technological development, is called a multi-target stool DNA, which is a long name for what everybody now knows as Cologuard, because they're the only company that's commercially producing this in the United States. And anybody who watches TV any time of the day will see multiple ads. We were actually in the colonoscopy procedure room the other day, and there was some music in the background, and the anesthesiologist turned to me and said, because we were listening to the radio, and we must have heard 10 ads from Cologuard while we're doing colonoscopy, and Cologuard, Cologuard, Cologuard. So it's kind of almost a humorous moment we had there. But this is a very, very good test for the average risk person who is unwilling to have a colonoscopy or would only do a colonoscopy if it was positive. And it basically is designed to pick up the different DNA mutations associated with colon cancer in the stool. So it does pick up a fair number of colon cancers. It was designed not to miss a colon cancer. So that winds up meaning that it has a high rate of false positives, because the company would rather have false positives that triggered a colonoscopy that's negative than to have a false negative, meaning that a cancer was missed and then was delayed until the development of symptoms. So it does engender a lot of concern amongst patients, because they get one, they assume they must have colon cancer, and then they obviously are very anxious until their colonoscopy. There are a fair number of false positives, but not always, obviously. And so that's why we have to take it very seriously. And it does still mandate a colonoscopy as the follow-up test. I would bring up a couple points in regard to the Cologuard. The first is that it is pretty good at finding colon cancer. It is not very good at finding precancerous polyps. So again, most of our work, we don't find colon cancer every day, fortunately. We do find precancerous polyps all the time, all day. And that's really what we're targeting on. So the Cologuard, while it might perform well to detect colon cancer, does not perform very well for finding a lot of the precancerous polyps. And as such, it was approved to be done every 3 years. Whereas if one has a negative colonoscopy and no family history, it's every 10 years, because it's a better test. The other thing that's come up that's very interesting is just an insurance issue. Most insurances will cover an individual for one screening. So we found out after this test came out that if people chose to get the Cologuard, the insurance would charge a copay and a deductible for the colonoscopy, because they now labeled it as a diagnostic, no longer a screening test. So they usually only give you one screening test to get it done. It's a little bit tricky, but that's unfortunately what happens. So sometimes the financial responsibility is going to be higher for the diagnostic test.
Hey, Sean, quick
yes.
question.
Yeah.
Somebody asked in regards to Cologuard, at what stage does Cologuard detect potential issues? Now, you mentioned that it's not very good at detecting the precancers or the polyps, but
yeah.
does it detect cancer at a pretty early stage? Is it pretty reliable for that?
That's a great question. So what happens with each of the polyps, as they get larger and larger, they develop progressive mutations. So a really small polyp probably won't be picked up by Cologuard. A moderate polyp will have a few more mutations and might get picked up. A large aggressive polyp still has more mutations and is more likely to get picked up, although the miss rate's still significant. And then by the time it gets to cancer, it has enough mutations that even in early stage cancer is typically picked up by the Cologuard.
Do you know offhand what the miss rate is for an advanced polyp?
I don't know off the top of my head, but for an advanced polyp, it's probably a miss rate of about 30%.
So 70%.
I have to look at. They have a monograph with a company broken down by different polyps, but but it's significant. Right. It's not negligible.
Right.
Yeah.
And one quick, and also and this might be something that you get to later on, but with the new recommendations for earlier screening, do you find that insurance companies are on board with these new recommendations, or are you struggling?
So actually, it's very interesting insurance process. About 2018, American Cancer Society came out and said, we recommend those at 45 get screened. Most of the insurance companies said, we don't care because we don't follow the American Cancer Society, even though I think most people would recognize that as a very reputable organization. So it wasn't until the last couple of years, as this thought process has gained momentum, that some have taken on the 45, but not all. With these guidelines, which are national, essentially well-regarded guidelines coming out in March, most insurance companies are covering 45, but not all. So you really would have to call your insurance company to find out if they will cover at 45.
And that goes for Cologuard and the colonoscopy?
It goes for Cologuard as well, yes.
Okay.
Although the specific language in the guidelines is that either a colonoscopy or a FIT is recommended, and a Cologuard CT colonography or this colon capsule, which is not often done, are to be considered if one is unwilling or unable to undergo FIT or colonoscopy.
Okay.
So
Okay,
I would
thank you.
say the force of it is colonoscopy and FIT, with a Cologuard kind of there as the next layer, as the first step of the next layer, if that's what one chooses.
Got it. And then one more quick question. What is the false positive rate for Cologuard? Do you actually have a number for that?
I think it's about in the 30% range. It's pretty significant.
It's pretty significant.
Yeah.
Yeah.
It's around that as well. And it part of that variance is as it goes up with age. So the false positive rate for a 50-year-old will be different than the false positive rate for a 70-year-old.
And do you know why the FIT is preferred over the Cologuard?
I think honestly, it's newer technology, more and more expensive. The FIT's really cheap. And so I think the thinking when you put these global things out there is offer an option. So for instance, a lot of the big institutions like Kaiser Permanente, Veterans Affairs, they need an option to provide mass screening. They can't afford colonoscopy for everybody. And so I think if you offer that, they'll have programs set up with FIT once a year where they just get mailed cards and things like that. So I think that's more where it came from. It's not so much that the Cologuard it does perform well for colon cancer, but it's more expensive as well. And so I think they were trying to balance those things.
Thank you.
I won't spend too much time on CT colonography, primarily because many insurances don't cover it. It still requires a bowel preparation. And the few patients I've had who have chosen that, actually, for many of them, found it quite uncomfortable because you're awake, still take the prep, and then the radiology technician, so nobody in the GI world, the radiology technician puts a tube in the bottom and inflates a bunch of air to do the CT scan. So it can be quite uncomfortable. But even more than that, it doesn't perform as well as the other tests we've talked about, and it's not covered by many insurances. The colon capsule is a great idea. The idea that you can swallow a capsule that can tumble down your intestines and take pictures of things. I'm not even sure it's covered by insurance, and I don't know a single institution that's doing it on a routine basis, a non-research basis. So that may come in the future, but is not commonly done.
Just a quick comment for probably more likely you've heard of the CT colonography as a virtual colonoscopy.
Thank you. Yes, that's correct. That's correct. And sometimes where we've done that is there are times when somebody might have had, say, multiple abdominal surgeries, so they have lots of scar tissue, and the colonoscopy is technically not able to be done. So the virtual colonoscopy might capture that portion of the colon that wasn't examined. So that might be a more typical role if we had to use that. So again, we talked about first step and second step. We talked about age 45 now. So that really is the age that's recommended and needs to be thought about. And then again, that's with no family history. If one has a family history, say of a father or mother, brother or sister with colon cancer, the usual rule is 10 years younger than that family member, or the age of 40, whichever comes first. Interestingly, we are now getting a lot of questions about when to stop doing colonoscopy. And so the guidelines are put forth for 75, and then from 75 to 85 based on a shared decision making with the individual, based on the individual's desire to continue, their expected lifespan. So if one has a lot of medical problems that might be more pertinent at the time, that's a lot different than the 85-year-old who's playing tennis and whose parents live to be 100 and take a cholesterol medication. So a lot of patients will come to me and say, well, I'm 74, 75, this is my last one, right? And I say, well, it kind of depends on what we find, how many polyps you have, what your future risk is, and how your health is. And so that's often a decision. And really, that's why we're so grateful to work with great primary care doctors, because that's a decision. We might see somebody every 5 years. You're seeing them all the time and can really say, whether or not this might benefit them as they continue on. And then you'll see here the verbiage, which is we recommend colonoscopy and FIT. Again, this is from the National GI Society. And for those unwilling or unable to, then they offer the other ones with Cologuard. The flexible sigmoidoscopy has really fallen out of favor. We used to do that quite a bit, but that's an unsedated scope over the lower third of the colon. Not very comfortable for a lot of people and doesn't look at a lot of the colon. So that's really fallen out of favor as well. So again, if you have no family history, it's colonoscopy every 10 years, which is probably one of the major selling points, or the FIT every year, or again, coming down to the Cologuard or the multi-target DNA every 3 years. There is a blood test that's being looked at. I think some people think, and there's a lot of tech research, that we're going to be able to get a panel of 30 proteins and they're going to be able to tell who's going to get cancer. Septin 9 has been looked at for colon cancer, but is not ready for prime time at all. We talked a little bit about the higher risk amongst African Americans. 45 has been proposed for a long time, but really now the entire population, regardless of gender, regardless of ethnicity or race, is 45. Okay. If you have a family history, you really need to talk to your primary care doctor because they can help you put the family history in context. My main comment about the family history as before is really get a family history. Call up your brother, call up your sister and say, hey, when you had your colonoscopy, what did they find? Because I think you might be surprised that they do find things and maybe forget to tell people. There's a large genetic component, but you don't have to have the genes. And then get a test scheduled. So how do you do that? Well, the first thing is obviously I'm a gastroenterologist, so this is what we do, but you talk to your primary care doctor and you ask them who they, what test would be right for you, who they trust, who they've worked with, who they think would take care of you in a good fashion, and then go get it done. It's one of those things we're really trying to dispel the concern over it's a sensitive area, or I don't want to talk about my bottom area, because this is such a common and really preventable thing. So taking control of your health, everybody's coming in now. We were talking before this talk started about now that many people have been vaccinated, or people are more comfortable coming back to the doctors. So this may be your first time in a year actually going in person to the doctor to get your cholesterol, but doing all of those things and getting screened is very important. They've put this great promo, which is no excuses. So they try to address all of the different, I feel fine. We've talked about that. It still doesn't mean that there's nothing there. So we would need to look at that. I'm healthy, why get screened? Same thing. You can guess where we all come from here. And again, 1 in 23, 1 in 25, 5 in 100 people, those are the sort of numbers we're talking about. And even if you have no family history. So the biggest modifiable risk factor is the getting screened. I would like to add one as we come down, women and men have the same. I would like to add one comment, in that I get asked a lot by patients, especially once or if polyps are found, well, doc, what can I do to try to prevent these polyps in the future? And so the biggest thing is to come back when we recommend you come back for your colonoscopy. But there are definitely some lifestyle things. So essentially all of the healthy stuff that your primary care docs here, I'm sure, tout frequently, exercise all the time, weights, cardio, everything all the time, maintain a normal weight because there's a higher risk of polyps and cancer if you're overweight. Probably less red meat. Certainly, I think less processed red meat. So a diet solely of beef jerky is probably not good for most of us. Minimize alcohol in minimal to moderation, not smoking, and probably a high fiber diet. So again, things that I think most of us would think are common sense, but they are very real and they do impact our risk here. So I would encourage anybody that's interested to partake of those. So that's
Sean,
all.
could I just interject one quick thing, partly because I have 4 kids eating by themselves and I'm going to need to leave soon. Something that always comes up for me trying to get people to get a colonoscopy is the safety of a colonoscopy.
Absolutely.
And I was explained about screening tests in general. And so this, I think I would just like to pass along to anybody who will ever listen. Screening tests are designed so that when they're done on the whole population, they're safer than if we don't do them on the whole population. And they also have to be designed to pick up a disease at a time when it is treatable. And so I'd love to hear how you explain that to people, but I think it's just so important to realize that getting a colonoscopy is safer than not getting a colonoscopy.
Absolutely. No, that's a great point. And I think first and foremost, even though colonoscopy is very common and we do it all the time, I think everybody does have to take it very seriously. I mean, it's a big day. I mean, you've taken a prep, you're going to be put to sleep, you're going to have a scope inserted and look at the colon. So we take that very, very seriously. And I think it needs to be taken seriously both by the patients, the doctors, the staff. I mean, it's a big thing that one undertakes to do. But the numbers are so in favor of getting screened that it's almost, I mean, so if one compares, let's say 1 in 25 risk of colon cancer for even numbers, the risk of bleeding from removing a large polyp is about 1 in 1,000. So if you come in and you have a polyp and we remove it, there is a risk of bleeding, and that can be it can lead to hospital admission, and it could be very serious, about 1 in 1,000. But if that polyp's not removed, it's probably going to grow to cancer. And then you become the 1 in 25 that gets cancer. So there's risk to everything that we do. There's risk to walking across the street. There's risk to driving home from work. But everything we do is calculated, and we try to make it as safe as possible and to reduce that risk. And so having an experienced colonoscopist, an experienced GI doctor, having an experienced anesthesiologist who works with that GI doctor, those are all very important things. I would imagine many people have also heard that there is a risk of perforation, which is puncture of the colon, and that's very, very serious and very concerning, obviously, if that were to happen. That risk is probably 1 in 5,000, depending on different studies, 1 in 3,000, 1 in 10,000. So it's not common, but again, if it happens, it's often when there's a large polyp we're trying to remove to prevent that from becoming cancer, the vast majority of which we remove just fine. And so I think when you consider those numbers, again, 1 versus 1 in 25 of getting cancer, that's why we really believe that this is the right thing to do for people.
Great. John, if you don't mind, if I can ask a couple of questions I have too. First of all, the baby aspirin every day has really taken a big hit as far as prevention of cardiovascular disease and strokes, but nobody ever mentions it in the realm of polyps, and somebody who has a high risk of polyps or somebody who's had polyps before. What's your take on that?
So that's a great question, and that comes up for several different GI conditions that might be the risk might be mitigated by taking aspirin. There's a small statement in actually the guideline, which I didn't get into, but they actually say if it's appropriate, essentially the principle is if it's appropriate to take aspirin for other medical conditions. And I believe that they phrase that as if your cardiovascular risk is greater than 10%. There's probably calculators that you guys use to kind of calculate someone's risk based on age and cholesterol and those sorts of things. But then if there's another reason, it also might help reduce the polyp formation. But to just take a baby aspirin without the other cardiovascular risk profiles has not been pushed, partly because there can also be some side effects from aspirin. There can be ulcers and digestive bleeding and stuff like that. So it's really looked at as if you have another reason to be on aspirin, oh, this is an additional reason at this time.
Right.
Thank you.
And the other thing we see is, there's a lot of variation. I know there's the pretty solid guidelines out there as to when you should follow up based on how many polyps you have, what kind of polyps, what your age and risk factors and whatnot are.
Sure.
And we see, us as primary care, we see a lot of variation in that. Can you speak to that as to why we might see that variation, why people do different things, or is it something that we're missing?
Yeah, no, that's a great question. And I think, there's guidelines, and then there's times when one doesn't follow the guidelines for a variety of factors. So the general guidelines for years have been one polyp over a centimeter or over, or 3 or more polyps gets you 3 years. 1 or 2 or small polyps get you 5 years, essentially, was where it was. And if you have a bunch of polyps, it gets you 1 year. So that's been the guidelines for years, and most of us that try to follow along those, that's typically what we recommend. Unfortunately, in March also, there were some recommendations put forth for colon polyp surveillance, with the intent of recognizing that a few small polyps probably doesn't convey that much risk, and you might even be able to go out even farther than the 5 years. The problem is it's like a menu of different things. So 1 or 2 adenomas, 7 to 10 years, 3 or 4 sessile polyps, 5 years. And it is very convoluted to follow the entire diagram, and it's very difficult. So that may explain some of the slight variation. And then also we do take into account family history. So sometimes I will have somebody who comes in and says, my dear cousin had colon cancer, and they were only 50, and I really don't want to get this. And that person in our literature is a second-degree relative. So they're really not supposed to confer that much risk. But again, with the shared decision-making, maybe they had a small polyp, maybe they didn't. They really are uncomfortable with 10 years. Would you bend a little bit to do 5, or could you do 7? I think there's some give there based on a patient. But the other flip side of that is I do think sometimes by talking with patients, they have to be cautioned that this is not something, there are some risks, and you don't want to do it all the time if you don't need it. We know that polyps take a while to grow. So let's do a good colonoscopy with a good prep, and then try to make a judicious interval that we all can be comfortable with.
Great, that's very helpful. Okay.
And there was a question about how long does the colonoscopy exam take on average?
So that's, yes, again,
Since we're sleeping, we may not know.
Yes. So somebody told me the other day, this week actually, goes, "You're great. It takes you 2 seconds." Because he's asleep. It takes us 2 seconds, and says, so I said, well, thank you for that. But no, typically it takes between 20 and 30 minutes. If it's if someone has a lot of polyps, it might take longer. If someone's had a lot of surgery, then sometimes technically it takes us a little longer because of the scar tissue to get around, but typically 20 to 30 minutes. And really with the anesthesia nowadays, within 15 minutes, I would say most people are pretty awake and feel pretty good and can have a lucid conversation afterwards.
What can they expect from when they show up at the door to when they can actually leave?
So yeah, so at least our process, and I think it's pretty similar amongst many places. Unfortunately, you're still required for paperwork. Nobody seems to get away from paperwork for anything. So we still have to, with obviously good intent, have a list of medical problems and current medications. The anesthesiologist will obviously review that ahead of before the procedure. And then basically people come in and they get an IV, and the nurse asks them a few questions like, when was the last time you ate? How did the bowel prep work? Going to start an IV and give them a blood pressure and heart rate, vital sign check. Then usually they'll talk with the anesthesiologist, who will bring them back to the room. I think one fear that sometimes people have is that they are never going to see the doctor. And at least the way that we practice, we always talk to everybody, of course, before the procedure. We've seen them before, but we talked in the office, but then we talk again before the procedure, go over everything. And then they'll lie on their left side, which is how the exam is done. Literally within 8 to 10 seconds after the anesthesiologist starts the medication, people start to drift off to sleep. And then we do the exam. And then frankly, about 15 minutes after we're done, when they wake up in the recovery room, most people, and I'm sure you have people on the Zoom call here who could hopefully attest to this, but most people will wake up and say, when are you going to start? Because there's usually sometimes some gas discomfort because we do put air in, but a lot of times that gas dissipates pretty quickly. And then the nurse will take out the IV. We'll go over the discussion of the findings with folks and our recommendations. Usually, if there's any biopsies, they get sent to the pathologist, usually about a week to 2, depending on the practice for those to come back. And then they're escorted out with their ride, and they have to have a ride to take them home. They can't be Uber or taxi. It has to be somebody they know for legal reasons. And then they usually go home, take a nap, and the next day they're back in action.
Sounds easy. Yeah.
And the dreaded prep solution, there's a question about which prep solution you recommend. Suprep?
So that's a great question, and it does vary by gastroenterologist. For anybody who remembers the old days, it was the big gallon jug, and you were just handed it and said drink, and it was very, very difficult. So we'd like to think we've made some improvements. So the smaller volume preps, which currently would include Suprep, Clenpick, Plenview, Movie Prep, those are all split preps. So you take a small dose the night before in Clenpick or Suprep, which are my primary ones that I use. They're either 5 or 6 ounces, depending on which one, mixed with water and followed by lots of water. And then the hard part is that the second phase of the prep is early in the morning. So if your procedure is at 7:30, you might be getting up at 2 a.m. to finish off the second part. But the intent of that is to really get clean right up to the time of the procedure. So you're as clean as it can be so that we can see everything, and those flat polyps we can see and take care of. So those are my favorite ones. We sometimes will use some extra laxatives if someone tends to be very constipated, because we want them to be cleaned out. But those are the more common ones. And then sometimes it depends on insurance, because I might give somebody Suprep, but if their insurance doesn't cover it, then we wind up going with something that they do. The one addition is there's now a Sutab, which is pill preparation. So we've all been waiting for a pill preparation that's safe. There was one a while ago that got taken off the market because of some kidney failure issues, primarily in women over 65. So that was, I think it technically wasn't taken off the market. It was just blackballed by the FDA with a big black box warning. So Sutab is very exciting because it's Suprep in tablet form. The problem is it's 12 huge horse pills the night before and 12 huge horse pills the next morning. So I'm not sure, if you're a real taste sensitive person and you can't drink the liquid, then that might be good. But a lot of people will have a hard time getting down big pills. So it kind of depends on the individual.
And how important is it to follow the diet pretty strictly on the day?
Incredibly, incredibly, because
important,
you see, any seeds, nuts, raw vegetables in the salad, poppy seed muffin that you might have eaten before, though that debris, if it's still in the colon, which it sometimes is, will clog the scope. And then we have to deal more with technically getting the scope unclogged than we do examining the colon. So it really is very important. I can tell you, doing this in a bunch of different settings for a variety of different, with a variety of different gastroenterologists and seeing how different people do it, I think the prep really is important. Nobody wants to follow it because it's uncomfortable again, but it really is important to get a good look, which is what the whole thing's about.
Right. Great. One other person wrote, if you're under age 50 and your insurance doesn't cover it from 45 to 50, can you petition the insurance? And I would add on to that, or would they be willing to cover one of the other options?
So I have not had success with anybody petitioning just because they want to, unfortunately. I have had success with suggesting to somebody, go home and talk to your siblings and your parents and see, because I bet you one of them has had a colonoscopy, and I bet you there's a good chance that somebody had polyps. And then labeling that with a family history of polyps is a code that then the insurance companies often will acknowledge. So that's probably the best way to do it. Certainly if one has symptoms of rectal bleeding or abdominal pain, that justifies doing a colonoscopy. Again, though, in the insurance eyes, it's often diagnostic, not screening. So there's a slight difference there. So the best way around it, I think, is if you can find a family history that would support doing what we all think is the right thing to do.
And that would be the colonoscopy, right? Because if you have a family history of colon cancer, the FIT test or the Cologuard is sort of off the table, correct?
Yeah, it's certainly not ideal. And we see a lot, unfortunately, especially because Cologuard can be self-ordered by patients. So some of what we've seen during this pandemic is people figured, well, I'll do the test kit at home because that's easy. And then I'll come for my colonoscopy whenever COVID precautions allow. Unfortunately, if they only cover one screening, a Cologuard every 3 years, and you have a negative Cologuard, they may not pay for your colonoscopy the next year when COVID restrictions are up. So there's a lot of logistics around that.
Sean, can I give a little a pre-prep eating tip that I had after my
Please do.
my
Yes.
first prep wasn't so good, and my second prep I had to do again another year. I read the directions a little better the second time around after I failed the first time. And I realized that instead of, eating all of the most fibrous, nutty, leafy, green things 2 days before the colonoscopy and then fasting, that perhaps it would have been better for me to eat only simple starches 2 days before my colonoscopy and then fast the day before. So 2 days before, I'm now recommending that everyone eat only French fries and toast and plain noodle soup. And then the day before, fast and drink ginger ale. But those simple starches are much easier to digest. And if you think you're going to be so deprived of salad that you have to overindulge like I did, it won't work very well. The other tip that Dr. Brower gave me, who was just a side tip that I was so appreciative of, is that we were all allowed to eat a little bit of lemon sorbet after swallowing that yucky stuff. So
that's a great tip, right? Right. So a couple comments there, which is great. So it's probably the only time I'll say that those simple starches are okay is the primary
exactly.
Don't get your doctor recommending French fries.
Yes, I
That's right. I know.
The vegetarians are actually often very hard to prep because they really want to have salad and and I eat a lot of vegetarian food, and you really want to have your salad and your nuts and your beans and all of that. But your statement is absolutely correct. The lemon sorbet, we have been advising, and that's nice to get the taste out of your mouth. One of the other tricks some people like is to sip it through a straw because it kind of just gets it down quick. When all these preps first came out, I think people thought, well, more is better. So if the doctor told me to drink it in 45 minutes, I should drink it in 10 minutes. And that creates a lot of nausea. So it's really okay to do it over the 45 minutes to an hour and then have your lemon sorbet for your palate.
Now, Sean, I know that I don't want to forget this question because it came up pretty early, and I know that this is a little bit off topic, but somebody did ask had a question about diverticulitis and diverticulosis, and the question is, what is the most current thinking on the cause of diverticulitis or diverticulosis for that matter, and recommendations for managing it to prevent flare-ups?
So that's great, and a great question. There's probably a lot of misconception out there. So diverticulosis is incredibly common, and those I essentially describe to people as the wrinkles in the lining of the colon. So as we all get older and we get wrinkles on our skin, we do also get wrinkles in our colon. It's just kind of the way our body, for many of us, is built. We sometimes see them in younger people, but more as a function of age for many people. The general numbers are 50% of people at age 50 have diverticulosis, 60% at age 60, 70% at age 70, 80%. So you can see how common it is. If anybody who comes at 50, about half the people we see will have diverticulosis. Interestingly, that in some countries that eat large amounts of grains, and roughage and that have multiple bowel movements a day, they don't seem to get much diverticulosis. And whether that's a genetic thing or a dietary thing, some think it's dietary, so a high fiber diet may be a good thing in that regard. The other numbers are about 95% of people with diverticulosis will never get diverticulitis. So the vast majority of people will not get diverticulitis. That leaves about 5%. And that's didn't used to be recognized. It was thought to be probably more common than that. But so the overall, just because one has diverticulosis does not mean at all that you're likely to get diverticulitis. The old wives' tale was you can't eat seeds and popcorn and nuts because they'll get trapped in these pockets and they'll get infected. I think in the last 20 years, I've had 3 people who told me they ate popcorn and then they got their episode, and so they won't eat popcorn again. But other than that, I really can't say. The actual research says it's an old wives' tale and it doesn't matter seeds, nuts, and actually we want to encourage fiber. So like people would avoid tomato seeds and some of these other softer seeds and fruits and vegetables, and that doesn't need to happen. Nor do I really think one needs to avoid nuts in general, unless your case is a unique sort of situation. But saying that, we don't totally know why diverticulitis occurs. There are some risk factors, and again, it sounds like repeating myself, but those risk factors are obesity, smoking, excessive alcohol consumption, probably excessive red meat consumption, and inactivity. So the only other one I'll add to that is chronic heavy NSAID use. So probably taking high dose Motrin for a long period of time does seem to lead to an increased risk as well. So if someone were to ask, those are the things that I would say to modify. So other than your 2 days of starches for your colonoscopy, your diet should be on point. You shouldn't be smoking. You should be exercising. And those are things one can do. But sometimes they get bad enough that it does require surgery. So it can be a difficult thing. I will bring up one other thing is that there is a relatively big movement that not all diverticulitis needs to be treated with antibiotics. So there's definitely a subset of people who get left lower quadrant abdominal discomfort. They've had it before. They kind of know this is the deal. They might get a low-grade temperature. They put themselves on a clear liquid diet, and then they call us on Monday and say, I think I had this, but I'm better now. And those people, I will offer them not to be treated with antibiotics. It's the people who have progressive severe pain, high fever, you're very concerned about when you examine their abdomen. Those people, obviously, we're still treating with antibiotics. But there is a movement for mild episodes to just go on clears for a couple of days and avoid, and then therefore you might avoid the potential side effects of the antibiotics.
Fantastic. That's great. And if I could switch back just to the original topic one more time, you've mentioned family history a number of times. You know, polyps are so incredibly common. If you go far enough with anybody, everybody has a family history, at least of polyps, not necessarily of colon cancer. So how do you define a family history of
So
polyps?
ideally, it's a first-degree relative, which is defined as a parent, sibling, or child.
At any age?
At any age, but a precancerous polyp. So for instance, some children or younger teens might get a colonoscopy and they might have what are called juvenile polyps, or another type of polyp that's not a precancerous 45, 50-year-old polyp. So, but we're talking about precancerous polyps. So that's really how it's defined. Now, there's certainly debate. If you have a great-grandmother who had a polyp at 90, that risk is probably not a whole lot to you. And as opposed to you have a brother who had a big polyp at 40, that's probably a significant risk to you. But in general, it's first degree relative, or if we're talking about cancer specifically, several second degree relatives. So if you have an aunt with 2 kids who all had colon cancer at the age of 50, even though they're not your first degree relative, that's still an important family history. And I would often start at age 40 for that individual.
Okay.
Very helpful.
Well, I think we've hit the 8 o'clock hour. This went by actually really, really quickly. This is so interesting. Dr. Hurley, thank you so much for,
Thank you.
yeah. So, So I don't know, Dr. Zweig, do you want to wrap things up? And
Yeah, no, I was going to do one last thing. I think that's looks like all the questions we have. So thank you so much for your time. Thank you for everybody to join. I think this was a terrific topic, and you really gave us some great information. And just one little teaser for our next town hall, Dr. Havert is going to be leading that one. So if you'd like to say a word or two about that, then we can move on.
Sure. Actually, this is really exciting. I mean, the last couple of town halls we've had, we had skin cancer, so skin cancer screening, and now colon cancer screening. And so we actually have Dr. Alex Christ, who's coming from the United States Preventative Task Force. He's a family physician. I actually trained under him at Fairfax Family Practice, but now he does a lot of work with the United States Preventative Task Force. And this is where these recommendations come from. These screening recommendations come from. So if you ever sort of wonder, it's like, well, how did these develop? How, who studied this? How did it come from? This is where it came from. And he'll be talking about how to be a good healthcare consumer. So, just understanding, the screening tests and which tests to do. And there's a lot of tests out there, and there are also some tests that probably you don't need to be doing. So, and how these recommendations have come about. So, it should be a very, very interesting talk, and I'm looking forward to that. That is June the 3rd. So in about a month, June the 3rd, Dr. Alex Christ.
Great. That sounds terrific. Yeah, very exciting. So, all right. Well, great. Well, we hope to see you all there. Thank you so much. If you come up with other questions later on, you can always try to email our general mailbox, and we can see if we can answer those at another time. But thank you, everybody, for joining, and I hope you all have a great night.